Hello, the topic of our lecture today is management of class 2 malocclusions. Okay, at the end of the topic, the student should be able to analyze the etiology and clinical features of class 2 division 1 and class 2 division 2 malocclusions. And the student should be able to explain and formulate the provisional treatment plan for class 2 division 1 and division 2 malocclusions. Okay, the definition of a class 2 malocclusion is a presence of anterior-posterior or AP discrepancy whereby the maxilla and or the maxillary dentition is positioned forwards in relation to the mandible or the mandibular dentition. Okay, class 2 malocclusion can be divided into two divisions, namely division 1 whereby the upper incisors are proclined, and you have division 2 whereby the upper incisors are retroclined. Okay, now a skeletal classification, the class 2 malocclusion is can be caused by two factors or combination of the two. One is the maxilla may be prognathic, or the mandible may be retrognathig, and or a combination of both maxillary prognathism and mandibular retrognathism. Okay, Van der Linden's classification of class 2 division 2, he divides class 2 division 2 into three types, namely type A, type B and type C. Now in type A, both the central and lateral incisors are retroclined, but the retroclination is mild. Whereas in type B, only the centrals are retroclined, whereby the lateral incisor overlaps the central incisors. In type C, both centrals and laterals are retroclined with the canines overlapping the lateral incisors. Now, what is the etiology of a class 2 malocclusion? You can broadly divide the factors into three groups: prenatal factors, natal factors and postnatal factors. Now, prenatal factors can be genetic or hereditary factors, could be the action of teratogens, irradiation during pregnancy, intrauterine fetal position. Example, if hands of the fetus lies over the face, that may impede mandibular development. Now, natal factors, that is factors during the birth process itself, usually involves improper forceps application during forceps delivery. Now, postnatal factors are factors after birth. It can be due to trauma to the condylar region, long-term irradiation, oral habits like digit sucking, and rheumatoid arthritis. What are the clinical features of a class 2 DIF1 malocclusion? Let's look at the extraoral features. The patient has a convex facial profile. The nasolabial angle may be increased. The chin is retrognathig. The upper lid is short and hypotonic, and the lips may be incompetent. There is lower lip trap. The labiomental sulcus is deep, and they may have a long face, meaning increased vertical facial proportions. Now, the intraoral features, we have a class 2 molar relationship. The upper incisors are proclined, leading to an increased overjet, an increased curve of spee, a V-shaped arch. There may be a posterior crossbite, and there may be a very deep overbite. Now, the clinical features of class 2 DIF2 malocclusion, extraorally they are also they have a convex facial profile. The lip line is very high, meaning the lower lip rests high up on the upper incisors. Now, this position of the lip is what causes the upper incisors to be retroclined. There may be lip overclosure, there may be hyperactive mentalis, which is evident as puckering of the chip, and there's a deep mentolabial sulcus, and they may have a short face syndrome, meaning the vertical facial proportion, lower vertical facial proportions are reduced. Okay, intraoral features of class 2 Dept malocclusion. There is class 2 molar relationship, retroclined central and or lateral incisors. Sometimes, rarely, even the canines are retroclined too. There's a reduced overjet. The overbite is normally very deep. The interincisal angle is increased, and the arch is usually a U-shaped arch. Now, what are the treatment objectives in a class 2 division 1 malocclusion? One, we want to relieve the crowding and correct local irregularities. We want to reduce the incisal overbite and also the incisal overjet, and we want to correct the class 2 relationship of the buccal segment. Now, what are the treatment strategies in a class 2 DIF1? There are three. One is growth modification, one is camouflage, and one is surgical correction. Now, growth modification aims to produce a skeletal change while restricting unfavorable growth while promoting favorable growth. Now, this treatment modality is most effective during period of growth acceleration, usually is the pubertal growth spurt. Now, meaning is best undertaken during mixed or early permanent dentition. Now, it is debatable whether true skeletal change can be achieved via growth modification, and success will depend on very good patient compliance. Now, growth modification for maxillary access or maxillary prognathism. Usually this involves using a headgear to restrict maxillary growth either in the AP direction or the vertical direction, or a combination of both directions. Now, the forces are usually transmitted via the upper molars. There are two types of headgears which can be used. The cervical pull headgear, where the force is directed more horizontally, and this can cause extrusion of molars and thus not suitable for high angle cases. Now, the other type of headgear is the occipital or high pull headgear, whereby the force is more vertical and posterior, and it causes intrusion of the molars, and this can be suitable for use in high angle cases. Now, for maxillary access combined with mandibular deficiency, the headgear is used to restrict the maxillary growth, but at the same time is combined with a functional appliance to promote mandibular growth. Now, an example of this would be the Van Beek activator, which has got a flying EOT tube for insertion of the headgear face bow. Now, for mandibular deficiency, normally growth modification is undertaken via use of myofunctional appliance to stimulate mandibular growth. Now, this promotes condylar lengthening and remodeling of glenoid fossa. The effect of this is both skeletal and dentoalveolar effect. The dentoalveolar effect involves differential eruption of the posterior teeth. Now, examples of appliances for this modality can be divided into either removable appliances or fixed appliances. Removable appliances are such as twin blocks, bionators, a function regulator, and an activator. A fixed one would be either be a Herbst appliance or a Jasper jumper. So these are pictures of these some of these appliances. What you see here is a twin block, and this is a bionator. This is a function regulated to and a fixed Herbst appliance. Now the twin block is widely used because it is the only myofunctional appliance which comes as two pieces and not one single large block, and thus it is more compliance is much better compared with the other types of myofunctional appliances. Now, the second modality of treatment is the camouflage treatment, and camouflage treatment can be done either with teeth extraction of teeth or without extraction of teeth. Now, camouflage treatment is normally utilized for patients who are past their growth and have no more growth potential in them. The objective is to improve dental relationships while accepting the skeletal discrepancy. Now, space will be required in the upper arch for overjet and overbite reduction and correcting any crowding in the upper arch, while space is required in the lower arch for correction of molar relationship, crowding, and overbite reduction. Now, the ideal teeth for extraction are the premolars, and usually the first premolars are extracted if more than 5 millimeters of space is required, whereas the second premolars are the teeth of choice if 2.5 to 5 millimeter of space is required. Now, camouflage treatment with teeth extraction, so we use the extraction spaces for overjet reduction, overbite reduction, and correction of all the crowding and local irregularities. Okay, now camouflage treatment without teeth extraction. This is undertaken in mild class 2 cases whereby the molar relationship discrepancy is less than half unit. Now the space is acquired by two methods. If there is spacing in the arch due to missing teeth, hypodontia, etc., this spacing can be utilized for overjet reduction. Now the other method is to do molar distalization. Okay, molar distalization can be undertaken through various appliances. For example, you have the pendulum appliance, you have Jones jig, you have distal jet, you have a ACCO appliance. This means acrylic cervical occipital appliance. You have fastback appliance, transpalatal arches. We can use intraoral repelling magnets, or we can even use the fixed functional appliances like Herbst or a Jasper jumper. Now, class 2 elastics is utilized especially when camouflage treatments are undertaken together with extraction. And class 2 elastics are usually stretched between the upper anterior segment to the lower posterior segment. Now the effect of class 2 elastic is to retract the upper labial segment while protracting the lower buccal segment. Okay, this comes from the horizontal force component of the elastics. Now there's also a vertical force component in the elastics which tends to extrude the upper anteriors and the lower posterior teeth. Therefore, these elastics are not suitable and should be used in caution in high angle cases. And elastics are normally used with fully bonded or banded fixed appliances. Now, sometimes when a class 2 diff 1 presents with a deep bite correction is necessary for overjet reduction. Okay, and this can be achieved by using a removable anterior bite plane which encourages eruption of the posterior teeth. Also, it can be undertaken using fixed appliances by the way of utility arches to intrude the anterior teeth. Now, sometimes a class 2 division 1 malocclusion may present with a posterior cross bite, as in cases of digit sucking habit, and this can be managed with corrected by use of a removable appliances carrying a jack screw or a coffin spring, or we could use fixed appliances such as the W arch or the quad helix. Okay, what are the treatment objectives in a class 2 division 2 malocclusion? One is we need to achieve relief of gingival trauma as due which can arise due to the deep bite. Then we need to correct the incisor relationship. We need to relieve crowding and correct local irregularities and correction of molar relationship. Now, the treatment strategies in a class 2 div 2 is one to extraction. Now, the extraction is done to relieve crowding, also helps in the correction of molar relationship and overjet reduction. Now, remember, you may be wondering why overjet reduction when a class 2 div 2 has no overjet. This is because once the incisors has been corrected to their normal inclination, you will get an overjet opening up. Okay, now we can the overbite can be reduced by using an anterior bite plane, or we can, which is a removable appliance, or we could use fixed appliances incorporating anchor bands or reverse curve or spee in the arch wire, and the inclination can be corrected using either extra torquing springs in the fixed appliances, or the arch wire could carry active torque adjustment to correct the incisor inclination. Okay, now if a class 2 div 2 is seen in a growing patient in the mixed dentition, then an appliance can be used to convert the class 2 div 2 to a class 2 div 1 by proclining the upper incisors, and once that is done, then a myofunctional appliances can be used as similarly we would do in a class 2 division 1 case. So basically, to summarize the treatment strategy for a class 2 malocclusion, the first thing we have to see if it is a skeletal problem or whether it is a dentoalveolar problem. Now, if it is a dentoalveolar problem, whether if it's a growing or non-growing patient, orthodontic treatment is carried out, conventional orthodontic treatment. Now, for skeletal problems, it's different whether the patient is growing or non-growing. In a patient that is growing, we can use either myofunctional appliances or headgear, or a combination of both, depending on where the skeletal problem is, whether it's in the maxilla, in the mandible, or whether it's in both. Now, in a non-growing patient, if it is mild to moderate class 2, then it can be undertaken, can be treated by orthodontic camouflage by extraction of teeth. Okay, in a severe class 2 skeletal pattern, then we will need to do a surgical correction, and again the type of surgical correction, whether single arch or both bi-arch surgery, will depend on the nature of the skeletal problem, whether it is the maxilla, the mandible, or combination of both. Okay, thank you.